Are we missing primary aldosteronism in our patients with hypertension? If you take care of adults with high blood pressure, the answer is probably yes, and it matters. Missed primary aldosteronism isn't just a blood pressure problem. It drives heart, vessel, and kidney injury that raises events and mortality even when the blood pressure number looks the same as in essential hypertension. Today, we're talking about when to screen for primary aldosteronism and how to do it without unnecessary hurdles. This episode is based on Things We Do for No Reason, Failing to Consider Primary Aldosteronism in Hypertension from the Journal of Hospital Medicine. Let's start with why this should be on your radar. Primary aldosteronism may be present in as many as 20% of people with hypertension, yet fewer than 3% of at-risk patients are ever tested. More than half of patients who do have it experience a diagnostic delay longer than 3 years. During that time, high aldosterone does more than raise blood pressure. It promotes inflammation and fibrosis in the heart, blood vessels, and kidneys, so the downstream risk of cardiovascular events, renal dysfunction, and death is higher than in essential hypertension at the same blood pressure level. So who deserves a screen? Think about resistant hypertension. Persistent pressure above 140/90 despite 3 drugs including a diuretic, or controlled pressure that requires 4 or more agents. You could also look for hypertension with hypokalemia, an incidental adrenal mass, or a family history of early onset hypertension or stroke. Those scenarios should reflexively move you towards testing. So what should you order? The preferred screen is the aldosterone-renin ratio, or ARR. Send a morning plasma aldosterone concentration and renin, either plasma renin activity or direct renin concentration. Aim to check after ambulatory blood pressure has been stabilized, and replete potassium beforehand because low potassium can suppress aldosterone and blunt the signal. Next, let's address a common myth. You do not need a prolonged medication washout to screen. The belief that you must hold antihypertensives for 4 weeks keeps screening on the back burner and puts patients at risk. Screening without a washout still has about 96% sensitivity. In other words, false negatives are uncommon. If it's unsafe to stop meds, and it usually is, don't. What happens after a positive screen? That's your cue to bring in an endocrinologist or a nephrologist to confirm the diagnosis outside the hospital. They'll decide on confirmatory testing and move towards subtype evaluation and targeted treatment. So that brings us to the final takeaway. Primary aldosteronism is common, underrecognized, and harmful. Don't let the myth of medication washout stop you. Screen the right patients, use the ARR correctly, replete potassium, and refer promptly when the screen is positive. Your patient's hearts, vessels, and kidneys will thank you. I'm Ryan O'Keefe. Thanks for listening to the Point of Care podcast. Check out pointofcaremedicine.com for checklists, admission templates, doc phrases, and other content. And subscribe to our Substack, where we distill our favorite medical literature, including reviews, trials, podcasts, cases, and videos, into quick reads.